Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
All right, welcome back to another episode of the PFC Podcast. This is Dennis, and I'm with Doug again, and today we're going to do a rehash of our analgesia and sedation, and we're going to push forward with a little more sedation and palliative care. So if you remember the last episode, we covered our priorities for analgesia, and I'll quickly rehash those. First is keep the patient alive. It does no good to set up a drip to make him comfortable, and then he dies 10 minutes later because you forgot to stop his bleeding. The next is sustain adequate physiology to maintain perfusion. If he doesn't have the perfusion, if he doesn't have the blood pressure to give him analgesia, do something about it. The last is relieve pain. So the approach we talked about last time is a two-drug approach. You're using your long-acting and your short-acting drugs combined to keep your patient comfortable. And remember, we're not talking 0 out of 10 on the pain scale. We're getting this patient into a plane that he is comfortable with what is going on. So today we're going to push into our fourth and fifth priorities. First being maintain safety. And in the CPG it states, agitation and anxiety may cause patients to do unwanted things, remove devices, pull lines, etc. Sedation may be needed to maintain patient safety. Number 5, no awareness during painful procedures, and during some mission requirements, amnesia may be desired. So I think to start this off, what we're going to do is a scenario. In our last deployment to the Democratic Republic of the Congo, we were tasked with training local park rangers on mobility operations. In the Virunga National Park is roughly 3,000 square miles, and we were 2 days into our training patrol. While driving down a 2-track, one of the ranger trucks decided to show off for the Americans and started hauling ass down the trail. Maybe a half mile further down the trail, we made a sharp turn. They didn't make the turn. Instead, they overshot and crashed into the trees. When we arrived, we ran to the vehicle to find that the driver had suffered massive facial trauma from the steering wheel, and the passenger was not in the truck at all. I began treating the driver while the rest of the team fanned out to look for the passenger. Luckily, the driver didn't have any arterial bleeding that I could see, but with the crushed mandible, the decision to do a ketamine crike was made for me. The rangers started shouting, so I assumed they had found the passenger. Chief ran over to me. He said, "This guy doesn't look good. He's breathing crazy, and his body is stiff and his arms are curled up." I had one of the rangers hold the driver's arms down while I drew out 50 milligrams of ketamine and gave it IM. While he started to relax, I made the cut and placed the crike. Once I confirmed placement, I asked the chief to maintain the airway to support spontaneous breathing. Running over to the passenger, I could see right away that there wasn't much I could do. He had progressed into full decerebrate posturing and had Cheyne-Stokes breathing. I told the guys to stop any bleeding, roll him into the recovery position, and start taking vitals. When I got back to Chief, I found him and the other ranger wrestling with the driver who was trying to remove his tube. Emergence delirium, I said to myself. I gave him another 50 milligrams IM and calmed him back down long enough to get an IV started and get his pain under control. I didn't think pain was his problem, just wherever he was, he didn't like it. The team leader was working the medevac, but it was going to be a few hours to get a plane out to us. Now what do I do? So this leads me to my first question for you, Doug. What is your decision process to determine if your patient needs sedation beyond analgesia?
Thanks, Dennis. There are a bunch of things that go through my head when I consider whether a patient needs sedation in addition to analgesia. In no particular order, one would be, have they undergone a procedure that is going to make them uncomfortable over the long term and potentially resist the procedure and you need to be sedated for the comfort of the procedure. And the big two in that was an endotracheal tube placed. And while I realize that guidance of the prolonged field care working group for airway management is to do a cricothyrotomy if definitive airway control is needed, because it does require less sedation medicines. It is better tolerated, it is more comfortable because the tube is placed below the gag reflex. If the patient is then ventilated, the actual administration of ventilator-assisted breaths can be uncomfortable. So endotracheal tube placement or with a ventilator, or cricothyrotomy placement with a ventilator, those would be two procedures where I would think that sedation would make the patient more comfortable and tolerate the procedure better. The second thing would be safety, and both safety of devices such as an endotracheal tube, a cric, or a chest tube over long-term transport, and as well as safety in flight. We recently ran our medical exercise mountain path, and on the fixed wing final leg of the flight, we had some great flight nurses that kind of worked with our role players to demonstrate just how dissociating the environment of flight can be to a critical casualty in transport. And they coached them to kind of, wake up, be disoriented, be delirious, pull out IVs, try to get off litter stands or litters and litter stanchions if they weren't physically restrained. And so flight can be an incredibly disorienting experience, especially, if you get loaded on the airframe unresponsive and then wake up in the middle of flight responsive. And so I would think about adding sedation to analgesia for a flight situation, particularly if it's prolonged. An additional consideration for our guys is operational safety, right? If they're in a place where making a noise could give away the position of a team, compromise the safety of a team, then adding some sedation to analgesia is more likely to reduce that risk of waking up and making a noise. And then finally, the third consideration would be comfort. So any long, uncomfortable transportation, I think some sedation in addition to analgesia is worth a thought. And any situation where you may want to induce some amnesia, and uncomfortable procedures, uncomfortable transportations, might be one of those. And several of the agents that we recommend in analgesia and sedation guideline is going to be published soon, and JSOM will induce amnesia as well.
What meds should we be using for sedation, or can we get what we need with opiates and ketamine?
Great question, and it leads to kind of one of the most misunderstood areas of analgesia and sedation use in critical care medicine, and even a lot of our practitioners don't always understand this. There are medicines that are specific analgesics. There are medicines that are specific sedatives, and there are medicines that do both. And the most important thing with the use of any medicine is to pick a medicine that provides you the effect that you want. So if you want to relieve pain, you have to pick an analgesic or a medicine that does both analgesia and sedation. And I'll get into some examples in a minute. In fact, I'll list them all out for you because it's really a pretty short list. And if you want to provide sedation, you should give a sedative or a medicine that does both. And yes, there's this school of thought that if you give high enough doses of analgesics, you provide sedation. What you provide is diminished responsiveness. You don't actually provide the brainwave effects of sedation as you could see on an electroencephalogram. And so it's sort of a falsely reassuring diminished level of responsiveness or unresponsiveness, but you're not actually, for lack of a better term, resting the brain or sedating the brain to calm it down in a way that a pure sedative would. So your pure analgesics are all the opioids in your pure sedative, as well as any other, non-opioid analgesic. Your pure sedatives are the benzodiazepines, midazolam, lorazepam, as well as propofol is a pure sedative. And in your mixed agents, at least in our toolkit, are ketamine. Ketamine is both a sedative and an analgesic. So in answer to your question, could we get what we need with opioids or ketamine? No for sedative effect from opioids, but absolutely for sedative and analgesic effects for ketamine. And that's one of the many reasons we like ketamine in an operational environment. I would recommend in our analgesia and sedation guideline, CPG, that's going to be published soon, would recommend that as a pure sedative, medics get familiar with and carry midazolam for a bunch of reasons. It is short acting. So if you give it and you get into trouble with its side effects, principally respiratory suppression, it'll wear off pretty quickly, and you can get through suppressing respirations probably with just bag masking, providing assisted ventilation with a bag mask for 15 to 20 minutes at the most, sometimes only 5 minutes, and not have to, take the airway if you haven't already taken it for respiratory suppression. The second thing is it adds a nice amnestic effect to ketamine. And the third is that it's first-line therapy for any emergence delirium or any uncomfortable side effects that you get with ketamine. I would, and the clinical practice guideline recommends giving adjunctive sedation with midazolam as an IV bolus, every 15 to 30 minutes, based on an objective assessment of the patient's level of sedation, which I think you're going to get to in a minute, and not either mixed with a ketamine infusion or as its own infusion, because unless you have the airway protected, you always have to consider what the risk is of running an entire bag of infusion in by accident. And Paul, was just over at a big training event in Europe, kind of reported that he actually saw this happen. They had a mixed bag of ketamine and midazolam, and somebody opened the stopcock and the whole thing ran in. Now, if it happens in training, it's a discussion. If it happens in real life, you may tank that guy, you may kill that guy, you may put him into cardiac arrest from respiratory depression.
Yeah, what I saw when this happened was exactly what Doug said. Somebody opened it up, they got distracted with what was going on in the room with other things, and then they forgot to close it back. So the whole thing went in over 30 minutes, and that was 150 milligrams of S-ketamine and 5 milligrams of midazolam. So I lowered the respiratory rate and the SpO2, but I didn't outright kill the patient, and I waited to see how long it would take these medics to find that, and it took 10 or 12 minutes. In the meantime, they were getting telemedicine information ready, and they said, hey, we don't have a GCS score. Let's get a GCS score. They tried getting the GCS from the guy. He wasn't rousable because he was sedated. And they said, okay, well, his GCS is 8. Let's tell that to the telemed doc. They tell the telemedicine doc that with his other injuries, they said, you're going to have to take the airway. So they got their crike kit out. And that's when we had to stop them and say, okay, here's the series of events that just happened and why you're about to take that airway. So it was a pretty interesting learning experience and why we're sharing it here.
Yeah, I think it's really important, especially in a very chaotic situation, to be able to take this kind of a tactical pause and think about what just happened. We say it and we beat it to death that you just get a intervention. What are you supposed to do? And you're supposed to reassess your patient. This medic gave a drug, but he got caught up in events. Life started happening, and he reacted to it. So this is why that I think anyway that kind of a tactical pause. Then we stop, think about what just happened. Is it working? Is it not working? Do I need to adjust fire, or can I just move on with what I need to do? So this kind of brings me to my next question. So when you're doing your sedation, you've already made the decision. You already know what drugs you want to do. How do you guide your sedation management, Doug, in the ICU?
So best practice in in the ICU and in clinical medicine for providing both sedation and analgesia is to do so in response to some sort of an objective assessment. And so for analgesia, we use things like the pain score, the 1 to 10 pain score. And sometimes we'll write different medications and different dosing for different levels of pain. Do this for pain 4 to 7 out of 10. Do this for pain 8 to 10 out of 10. Do this for, pain 8 to 10 out of 10 if they can't take an oral. And there are actually pain scores for unresponsive patients, which we may get into in sort of Analgesia 201 in a future podcast. Or you can, you can email me through the website and I'll be happy to comment. For sedation, there are a couple different scores, but one of the easiest to work with and one of the best validated is something called the Richmond Agitation and Sedation Scale, or the RASS, RASS score. And this is a -5 to +5 level score or +4 level score, with all of the pluses being more agitated and all the minuses being more sedated. And there's a copy of this that's going to be attached to this podcast on the website. And what we're shooting for is lightly sedated in general, so a RASS of -2. And because that's been associated with kind of the best outcomes and the fewest side effects. And to touch on an earlier point, guidelines for using medicines with such really severe side effects, respiratory depression, cardiac arrest, and, circulatory collapse and death. These are no joke medications that we're talking about in these analgesia and sedation discussions, is to maximize effect and minimize side effect. And that's exactly where you're hitting the sweet spot if you hit a RASS of -2 light sedation, potentially a RASS of -3 moderate sedation. But you want to be able to have your patient wake up easily, unless they have an injury, such as a brain injury, such as a severe brain injury that might make it impossible for them to wake up clinically. You want them to wake up easily, either to voice or to a very light touch. And that's that -2 to -3. One of the other reasons you want them to be able to wake up fairly easily is you want to be able to reassess them. You want to know if that patient who has polytrauma from a motor vehicle accident, an ejection, an ATV accident, is developing a brain injury. And if you've got them so deeply sedated that you can't wake them up, you don't know if you're not able to wake them up because of your medicine or because they're developing a severe brain injury. And that's another thing that argued in favor for us when we worked on the guidelines of bolus sedation as needed rather than a drip. Is it's easier. There's very different pharmacodynamics. I hate to use a word like pharmacodynamics in a podcast, but it's how the medicine acts. Sedative medicines act completely differently in the body in terms of a half-life if given as a drip than they do if given as an IV push. If you give it as an IV push, their half-life is very predictable. You push Versed, midazolam, it'll last 15 to 30 minutes and it'll wear off. You give it as an infusion, it might wear off in 15 to 30 minutes in the first hour to 2 hours that you give it. It might wear off in hours to as much as a day if it's been running it as a drip uninterrupted for a day, because it's soaked into the fat cells of the body and then has to leach out over that prolonged infusion time, then has to leach out, get remetabolized, and as it's doing that, it's still having its effects.
And Doug, tell me if I'm wrong, but what we're trying to do is we're trying to stay away from, we talked about in the Analgesia podcast, from making this patient stoned. He can kind of sense what's going on, but he can't really react to what the truth of the situation is going on. So whatever story is playing in his head, he's reacting to it. And that goes along with what we talked about before with PTSD or ICU delirium, things like that. So we're trying to give this guy his analgesia, get him to a comfortable place. And if he needs a little bit extra, we're gonna put him in an even more comfortable place with our sedatives. Does that be correct?
Exactly right. There's some really interesting data from the psychiatry world that PTSD is associated with the absence of memory and not bad memory, and that it's gaps in memory and recollection of a traumatic event that may be more associated with PTSD. And so that's yet another thing that we think might be a benefit of light to moderate sedation, adequate but not excessive analgesia, is that these patients retain some awareness of what's going on, some memory, and an unbroken record of the event that may minimize PTSD.
You had mentioned waking up the patients once a day. So when you're doing these, when you're doing these sedation wake ups, say I have this patient for 72 hours. I can't just run a drip for 72 hours. I have to, at some point, I have to assess what's going on, if he's progressing or not. So what exactly happens during these sedation wake ups?
Right. Thanks for raising that question. The concept of awakening trials and then spontaneous breathing trials and critical care medicine kind of grew from an awareness that there are two things that really creep up in intensive care medicine. And when you're in prolonged field care, taking care of a critically ill or critically injured patient, for more than a few hours, you're getting into austere critical care. And certainly when you're taking care of them for more than a day or 2 days, you're really running an austere intensive care unit. And therefore, as best as possible, try to implement the best practices from clinical intensive care units to your austere setting is going to just be some of the details that help your patient to have the best outcome. So I mentioned things that creep. The two things that creep are analgesia, sedation, and fluids, right? And that's because, and there are actually studies on this. There's studies on fluids and a lot of interesting studies in the burn literature, and there are definitely studies on analgesia and sedation in the intensive care literature that shows that for some reason, we want to give more and we're less inclined to give less and cut back, right? If some pain medicine is good, more must be better. If some sedation is good, more must be better. Oh, the patient flinched, they must be in pain. Give them, and this really has a potentially bad effect when the medicines that you're giving are given in the form of infusions, right? If all we did in the ICU was give IV pushes, we wouldn't really have this issue. But because we run drips, because we've got other things going on with our patient, because we think they have ongoing pain and anxiety issues, when we want to, take care of them steady state, we run them as infusions. And when these infusions get ratcheted up and never turned down, they build up in the body, their metabolites build up in the body, and they cause all sorts of negative side effects, from physical side effects like respiratory suppression, actually increasing a risk of PTSD because of potentially creating memory gaps, to just things like the patient needs to be in the ICU longer because because they can't breathe because they're over-sedated, or they need to be on a ventilator longer because we can't extubate them because they're over-sedated. And so that's really what drove these guidelines that every day, with only a couple of exceptions, none of which really apply, I don't think, in a prolonged field care setting. You should turn off all the sedation, turn off all the analgesia drips, and then assess your patient and do a neuro exam just to make sure that they haven't developed, some sort of a brain injury in the interval. And then when you restart them, start them at 50% of their previous levels. That will guard against the creep. And many times I've seen you don't need to restart them at all. More frequently, you can restart them at half of the previous dose, and you realize that dose is escalated to the point where they're perfectly comfortable on their 50% dose. And I did mention that the other thing that creeps is fluids. So we're not going to talk about fluids today.
And I think that's really also the benefit of having these scales. When you have a patient that's sedated, and when you try to rouse them for whatever reason you decided you want to talk to them, suddenly they're not responding. Or you move to the next, you're moving down your AVPU, you decide to shake your shoulder, And now he used to look at you when you would talk to him, and now you have to shake his shoulder. Hey, maybe, I've probably turned the drip eye a little bit too high. Maybe I can turn it down just a little bit.
Yeah, and as I'm thinking, I do want to give a caveat that you should be in a place that's safe when you do this. And if you're on a plane and the risk of the patient waking up and being delirious and falling off a litter stand is high, then you wouldn't do it there. If you're in a situation where basically any place where the patient is unsafe or the patient being agitated could make the team unsafe, then you wouldn't do it. And like with everything else, you want to prep for both outcomes. You want to prep for the outcome that they don't wake up, and think about, what's your differential diagnosis for them not waking up. And you want to prep for them waking up agitated. So, I would do in the ICU, it's easy. We always have a sedation drip that we could just turn right back on again. There's syringes all over the place. We can easily draw up some propofol or some Versed and give them a push. Same thing for you if you want to, if you are doing an awakening trial, draw up 5 milligrams of midazolam. And if they really wake up and they're agitated and combative, give them the midazolam push to calm them down. Maybe increase their baseline sedation drip, maybe think about restraining them, and then maybe not doing it again until they get to definitive care. Because they're getting to definitive care. We are in a PFC environment. They are going to get to definitive care. But those are some other considerations. Like everything you do, don't just do it. Think about what the ramifications of doing it and prepare for both.
The one thing I wanted to add on to all this is make sure you get your baseline neuro exam. So get your GCS or get your main neuro or mental status, whatever you're going to do it early prior to getting that sedation on so that you can track the trends and changes later on. As you saw in the scenario I talked about, they were trying to get that while the guy was sedated because they didn't get it prior to sedation and analgesia. So that led him down a wrong path.
One last thing I'd like to add to this GCS or RAS or really any score is the reason why they push these things is that it aids in communication. So say I'm overseas and I'm talking to Doug and I'm trying to explain where my patient is. It's going to be kind of difficult if I say, well, he's kind of sedated and he's a little sleepy and, he kind of moves around, and Doug's going to look at me like I'm a moron. And he's going to respond to me like I'm a moron. So on the other hand, if I tell him, okay, here's a RAS of 0, he knows exactly what that is. And I know exactly what it is, not because I'm smart, it's because I'm looking at a chart that I've printed out, but the communication is exactly the same. We're speaking the same language. Likewise, when Doug tells me I want you to increase sedation and bring his RAS to a -2, well, I know exactly what that is. Okay, I know it says lightly sedation, but I'm going to start looking for him waking up when I talk to him, and he's going to sustain eye contact, and probably just under 10 seconds. But he's going to look at me, and he's going to look directly at me. The communication is there.
Yeah, I just wanted to ask one more question. When you're doing a sedation wake up or a sedation holiday, and the guy's intubated or criked, can you still do the neuro exam?
Absolutely. There are two parts of the Glasgow Coma Scale. There's intubated, which basically any advanced airway down the trachea, which is everything except your verbal score. So it's your motor and it's your eye responsiveness, and then your verbal score is automatically a 1 because they're nonverbal, because you're interfering with their vocal cords. And so the maximum score on that is 11. And then you put a T after that, intubating that they have a definitive airway. And then there's the unintubated, no advanced airway, which is 15. So absolutely you can do that. There's a great neurological exam that you can do in your intubated patient along with the GCS, where you basically ask if ask them to move all their extremities, right? So both upper extremities, wiggle your fingers or give me a thumbs up, wiggle your toes, give me a thumbs up, for extremities that haven't been amputated. And that's getting your entire motor cortex, right? So that's, left and right, you have an assessment that their entire motor cortex is working. And then if you do pupillary light and accommodation, right, you shine a light in their eyes and a perla on both sides, that gets their entire ocular nerve or optic nerve pathway, which basically goes through both frontal lobes, both temporal lobes, into the occipital lobe. And that grossly the pathway through all of those lobes, just by checking the optic nerve, is uninjured. And then finally, you test their brainstem reflexes, which is cough and gag. And in an intubated patient, you just, suction them is a good way to do that. And if they cough and they gag, then you've checked essentially that that some of their deep brain reflexes are intact, and then also assess if they're breathing spontaneously. So if the ventilator rate is set for, let's say, 12 and they're breathing 20 times a minute, that they're taking spontaneous ventilations. You've essentially checked their entire brainstem. And that was taught to me by a neurointensivist during my training at Walter Reed. And it's basically, it checks every geographic aspect of the brain down to the brainstem in a intubated or criked patient off sedation. And if you get that plus your GCS of 11T, you can be reassured that your patient's neurologic function is pretty intact. And I have Dr. Van Wyk, who is a neurointensivist, sitting here smiling and nodding. So I know I'm not talking complete garbage.
So Doug, one last question. So say I've screwed up completely. So I have accidentally ran in my bag of sedatives, and now he is completely unarousable. What can I do about that?
So if you ran in a complete bag of ketamine, you don't really have that much to worry about. They're going to be probably over-sedated for a while, but their respiratory drive won't be suppressed, and almost never suppressed. And it's just going to take you for a while for you to get them to lighten up, to get to the RAS level that you like. And that's one of the reasons that we recommend giving ketamine as your infusion, and then your drugs that suppress respiratory depression, like midazolam, as a bolus. If you do hang a separate, and certainly separate them, right? So that if you do run in an entire bag, which bag you ran in, which volume or which dose you're dealing with, and then you can kind of decide, what your strategy is for dealing with that. If you do want to do midazolam as an infusion, put it in a separate bag. So if you ran in an entire dose of midazolam, or, you handed a syringe with, let's say, 20 milligrams of midazolam in it and said, push a quarter of this for 5, and they wind up pushing a half and realizing they pushed too much, or God forbid the whole thing, at least you know what you do with it. I would always give, your main side effect that you're dealing with is going to be respiratory depression, almost certainly. I would always give a trial of bagging the patient, giving mask ventilations, bag valve mask ventilations in a patient without a definitive airway, to see how they do. In a patient with a definitive airway, like a crike just for airway protection, who's not hooked up to a ventilator, again, I would just hook up a bag and bag for them as well. If you get to the 30-minute point and they're not really coming around, and they don't have an airway, you could consider a reversal agent, like flumazenil, if it's a benzodiazepine. If you give them a narcotic overdose, Narcan, as well, even though we're talking about sedation here, and see how they do. But be aware that the half-life of your reversal agents is often shorter than the half-life of your drugs, of your drug side effects. So, an overdose of midazolam, 1 dose of flumazenil, probably going to take care of you, because they both have fairly short half-lives. Overdose of morphine will definitely come back, and come back, or the side effects of that will definitely come back faster than a dose of naloxone or Narcan will wear off. So be aware of the drug, be aware of the half-life of the drug. I'm sorry, but we do have to do pharmacology if we're going to do prolonged field care, and then have your strategy as well. A infrequent but frightening side effect of flumazenil reversal of benzodiazepines is seizures. Now, this is seen much more in patients who overdose on benzodiazepines, who are chronic benzodiazepine users, patients who take lorazepam for anxiety, patients who take diazepam or Valium for anxiety. But it's not unheard of in patients who are just getting sedation. So, interestingly enough, the treatment for seizures is more benzodiazepines. But at that point, you probably are going to be hopefully phoning a friend. Hopefully you got a friend to phone. But you can give flumazenil, see seizures, in which case you're basically got to hop back on the train you're trying to get off and give them a benzo to break the seizure. And at that point, you're probably looking at taking an airway, but hopefully phoning a friend as well.
Yeah, the only thing I wanted to add on to that is just recognize the escalation of force. And I think Doug kind of talked about it a little bit, but the first thing you should do is try to arouse your patient. Hey, wake up, take a breath. Can you hear me? If that doesn't work, then you can move on to the BVM. I see a lot of medics are really comfortable in cracking, so that's usually their big gun and they go right to it. But this is not that situation where you go straight to that crack. So try the less invasive things first in this situation, unless it's an absolute emergency and there's no other options.
So now I'd like to briefly summarize what we've gone over today. We're sedating our patients for two reasons: patient comfort, so that they're able to tolerate the interventions we've given them, and patient safety, so they're not hurting themselves by pulling out lines, taking off splints, falling off the litter stand, or they're not causing our team any extra problems by creating noise or actually using the weapons that they have on them. The two medications we're going to be using are midazolam and propofol. These are pure, short-acting sedatives. And what we're going to do is either use an IV push, or if we are going to set up a bag and drip it in, we're going to connect a dial-a-flow. These are cheap, they're in the tech set, and they control the flow with the twist of a knob. If our patient's hemodynamics are not the greatest, we haven't finished our resuscitation, we're going to take a cue from our Analgesia podcast. We're going to start off low and start building up from there. And we're going to control this sedation using our vital signs and the RAS score. Thank you for tuning in. I'll see you next time. That's another one for the books. Make sure to go to the site, www.prolongedfieldcare.org. Post your questions, post your comments, make your voice heard. This is Dennis for the PFC Podcast. Out. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.